Our webinar topic today is Scott Trigger's Solution. Our presenter, Susan Scott, is currently a medical educator with the University of Tennessee Health Science Center, Office of Graduate Medical Education in Memphis, Tennessee, and an independent consultant for Scott Triggers, PLLC. Here are the presenter's disclosures. After today's presentation, you should be able to identify current trends in incidents, litigation, cost, and regulations for hospital-acquired pressure injury, describe evidence-based tools and techniques to reduce the risk of pressure injuries at each stage of perioperative care, and illustrate the use of Scott Trigger's quality improvement strategy in a formal perioperative pressure injury prevention program. Now I'd like to turn the program over to Susie to begin.
Good morning, everyone. This is Susie Scott. We've known about perioperative pressure injuries for over 100 years. In 1901, the first unexplained burn case reached the Supreme Court of New York. And in 1980, Gendron wrote, "Surgery is one of the few times when a normal, healthy individual is placed at risk for pressure sores. For that reason, I support adding risk of pressure injury to the informed consent." I call this the year of the awakening. 2.5 million individuals develop hospital-acquired pressure injuries in U.S. acute care facilities each year. The cost to the U.S. is a staggering $26.8 billion. The Padula study estimated that 59% of that cost occurs in the stage 3 and 4 pressure injury occurrence, which has been denied payment under our current CMS model since 2008. In 2019 alone, over 600 hospitals were penalized between 1% and 3% of Medicare reimbursement. Make no mistake, this is a public health crisis. Now, Benjamin Franklin once said, "An ounce of prevention is worth a pound of cure." And this is still true today. A pressure injury can cost from $500 to $70,000 per episode. A stage 4 can be as high as $128,000 per case. There have been studies that have looked at the percent of hospital-acquired pressure injuries that occur in surgical patients, and this has been as high as 45%. The rate in a recent meta-analysis of 9,500 surgical patients was almost 19%. And litigation is second only to wrongful death cases, with 17,000 new cases filed each year and an average settlement of $250,000 per case. The business case for prevention has never been stronger. Now, this slide shows the Agency for Healthcare Research and Quality National Scorecard on hospital-acquired conditions. We've seen a significant decline in hospital-acquired conditions, or HACs, over the years, except for two areas: surgical site infections, where the numbers are flat, and pressure injury, where there was a 6% increase between 2014 and 2017. And if you're in an academic medical center, that rate increased by 30%. And this is only going to get worse. Take the silver tsunami. The adult population aged 65 and older is expected to grow to 37 million by 2030 and double to 89 million by 2050. This will increase the demand for surgery in this at-risk population. And to compound the problem is the obesity epidemic. 74.1% of our population is now overweight or obese, with an estimated 2.6 comorbid conditions. So the first step toward high reliability is to have a vision. We want to provide safe care across the continuum by turning our highest risk areas into low risk. And it starts with a strategy. I like the ABCDE model first described by ILO and Leiter, and I've added a few more pieces. Administration or leadership is critical to high reliability. They provide the resources, support, they set policy, monitor quality data, and patient safety reports. Bundling care practices, simply put, is integrating the evidence into our clinical practice routines. These are key drivers to achieving our outcome. Culture and change are integrated, and communication is a key component of patient safety. Documentation is now morphing into decision support systems and use of artificial intelligence to drive our evidence-based practice. Education equates to competency that builds our knowledge and skills and changes our attitude about safety. Now, one of the quality strategies that I always recommend is to perform a gap analysis. And you want to define your current state of practice and plan for the desired state. Your assessment should include all your available data, audits and incident reports, and hopefully you're conducting root cause analysis. Define those key drivers to achieving your outcomes and plan your processes. Assess your current state of equipment and devices and the availability to the end user. I recently visited a facility where we assessed every area in the hospital where a patient could be immobile for over 2 hours. It was truly an eye-opener. This horizontal approach can help leaders identify potential barriers to patient safety across the continuum. So let's look at the operating room. AORN is very clear that the goals of patient positioning are to eliminate patient harm. They recommend that the registered nurse perform a preoperative patient assessment to identify patients at risk for positioning injury, develop a plan of care, and implement interventions to prevent injury. One of the best ways to accomplish this is to integrate the AORN guidelines into an OR skin bundle where evidence-based best practices become standard work. This approach is maybe fairly new, but we're already seeing some promising results. I want to review each of these individually. I call this the 11 keys to success. It starts with risk and skin assessments. So AORN standards suggest that there's strong evidence for conducting a preoperative risk assessment. However, the traditional risk assessment tools, such as the Braden scale, has limitations in surgical patients. A meta-analysis conducted by he and colleagues suggests the Braden scale cannot be used alone in surgical patients because of its low predictive validity for assessing pressure injury risk. The newest AORN guidelines on positioning include surgery-specific tools, the Monroe scale and the Scott triggers. The Braden QD scale is now recommended in the pediatric population, although I don't believe it's been tested in the surgical population yet. The Scott triggers is a surgery-validated tool that was developed from our research in Memphis, Tennessee. It's an example of a concurrent trigger system using 4 main factors: age over 62, albumin level less than 3.5, or BMI less than 19 or greater than 40, the ASA score of 3 or greater, and time on the table at 3 hours or longer. 2 or more factors indicate a patient who is at risk. The tool is the subject of numerous research studies and is in a recent peer-reviewed publication of a retrospective case control study of 400 patients by Park et al. In South Korea. They concluded the Scott trigger tool was the best fitting model with the highest sensitivity and the highest negative predictive value over the Braden scale. Now, this is an exciting development. This screenshot was taken from the EPIC platform at Johns Hopkins Hospital, where they integrated the Scott Triggers tool and linked it to an OR skin bundle. The factors self-populate, and trigger an alert to the OR team that the patient is at risk. The nursing staff can select the proposed position, and a list of actions populate, including specific positioning devices. This helps to build that knowledge, competence, and improve documentation. Terry Emerson, the nurse manager there, recently published an article in AORN and reported a 50% reduction in hospital-acquired pressure injuries in the first 6 months of implementing this strategy. Now, as a wound ostomy continence nurse, I can't emphasize enough the importance of a full-body skin assessment before and after surgery. This is a critical competency for perioperative staff. Accurate, timely, documented skin assessments establish the baseline and drive prevention protocols. Efforts should be made to teach OR nurses and perioperative staff how to assess the skin systematically within your pre-op routine. They must also learn how to describe and stage assessed areas and document all assessments in the medical record. The key to assessing skin is doing it with your routine task. A best practice was a QI project that I was aware of, where the skin was assessed on all patients having surgery longer than 2 hours. I also recommend that you review my webinar on skin assessment that will be in the AORN toolkit. Skin assessments are performed pre-op and post-op and at least daily. A 4-eye skin assessment immediately post-op and 4 hours after transfer is a best practice. Observe the pressure points and under medical devices and report both blanchable and non-blanchable erythema. Pain may be one of the first indicators of a pressure or nerve injury, so you want to report that if there's any positive findings. The second key is safe patient handling. This affects both perioperative staff and the patients as well. The average nurse lifts over 1.8 tons. 50% of nurses complain of back pain at some point in their career. The average surgical patient has 6 or more lateral transfers per episode, which significantly increases tissue distortion, shearing forces, and friction. Now, there are multiple guidelines and groups working on safety, but look at this from the AORN guidelines. For patients over 157 pounds, you should use mechanical lifts with supine sling, a mechanical lateral transfer device or air-assisted lateral transfer device, and 3 to 4 caregivers. So the question is, how many of your patients are over 157 pounds? And most of the time, that answer is almost all of them. So this should be the standard of care. Now, high specification support surfaces was the focus of my research, and it's also a recommendation from the National Pressure Injury Advisory Panel. In the Memphis VA study, we compared a standard 2-inch foam pad with a 4-inch high specification pad. Patients were 8 times more likely to develop a pressure injury on the standard pad versus the high specification pad. So this can be a significant contributor to high pressures over bony prominences. Effective surfaces provide both immersion and envelopment to offload pressure. Now, there are 2 types of OR table pads currently on the market. There are non-powered pads, which include foam and gel and air equivalents. And then there are powered devices. And these all have limited evidence to support their efficacy. But what we want in the OR is a pad that has a therapeutic weight capacity to support the patient's load and provides immersion and envelopment. Immersion refers to the depth of penetration into the support surface by the patient's body. Envelopment is the ability of the support surface to conform around the body. As the body contact area with the support material increases, the pressure will decrease. So determining efficacy can be complicated. Tissue interface pressures give us a visual cue, but the colors really don't mean anything. You need to look at the numbers that are associated with the colors. The scales can be easily manipulated. There is emerging technology, thermography, high-frequency ultrasound, and subepidermal moisture scanning that can give us information on tissue damage microscopically or subdermally before it becomes visible. There was a study by Grapp who used high-frequency ultrasound and found only 1 hour of OR time was significant for sacral skin damage. The OR of the future may include this type of scanning in a preoperative assessment. S3I testing lab is another way that OR products are evaluated for efficacy. And then we have CT scans, MRIs, and PET scans, but those are limited. One issue that's come up recently is about infection control of our OR table pads. There was an ECRI technology bulletin that was published in 2009 that said that healthcare facilities should regularly inspect mattresses and covers for signs of damage or contamination. This needs to be put on your audit list and replace mattresses that have been compromised. Now, redistributing pressure and padding bony prominences is the fourth key to success. The team needs to assess and be aware of pressure points before and after surgery. Positioning competencies should be taught annually. These are a list of high-risk pressure areas in both the supine and the prone position. It's important to assess these and document any abnormalities in your medical records. The fifth key is to offload pressure in the heels while maintaining the knees in slight flexion. Heels are vulnerable in the supine and lithotomy position. These studies show that the pressure injury rate in surgical patients can be as high as 52%. And you can see from the protruding calcaneus bone why the heel is a vulnerable piece of anatomy. Both AORN and the National Pressure Injury Advisory Panel recommend to choose a device that offloads the heel and distributes the weight along the calf without putting pressure on the Achilles tendon. Hyperextension of the knee can lead to popliteal vein compression and increase your risk for deep vein thrombosis. AORN states that there is high evidence to support the use of prophylactic dressings for bony prominences and under medical devices. But remember, this is not a substitute for pressure redistribution practices. There's limited studies in the operating room, but I'm seeing that change. And there's been some case studies and QI activities that have shown prone kits using prophylactic dressings have been effective. You always want to avoid the use of unapproved positioning devices. Items such as blanket rolls, towel rolls, and IV bags are not intended for pressure redistribution. They do not have manufacturer's instructions for use and are not FDA approved for positioning. These have been linked to pressure and nerve injuries. And the candy cane stirrups were invented in the Civil War. They've been linked with peroneal nerve injury resulting in permanent foot drop. If at all possible, these need to be transitioned into a boot-type stirrup that has safer features for preventing nerve injury in your patient population. I want to briefly mention microclimate and hypothermia. Microclimate is the temperature of the body and the amount of moisture between the body and the surface. The effect of excessive temperature on the skin starts with sweating and perspiration, leading to excessive moisture, which can macerate the skin and weaken the epidermis. Yoshimura found that for every degree the body temperature was raised, that it increased the risk for pressure injury in this park bench position. In contrast, hypothermia has been linked with multiple complications, including surgical site infection, increased length of stay, and mortality. Fred found that for every degree of Fahrenheit the body temperature was decreased was linked with a higher rate of pressure injury. So the goal is to maintain normothermia. This is the process of keeping the patient's temperature at a normal level, which is 96.8 to 100 degrees, 100.4 degrees Fahrenheit, 36 to 38 degrees centigrade. Key drivers in the operating room may include the items listed here: hypothermia protocols, devices that provide warming or cooling, maintaining the room temperature. The photo here on the right shows a drape that actually wicks moisture away from the skin and may help with microclimate. Handover communication. The Joint Commission reports that 70% of adverse events are the result of communication errors. Structured, standardized handoff communication tools such as IPASS, shown here, or SBAR are recommended. We should include the surgical position, the time on the table, the risk, and the skin assessment during all handoffs. AORN states that the perioperative RN should collaborate with the peri-anesthesia RN to identify injury from position. One best practice that I have identified is from John Muir Health in California. They conduct a 4-eye skin assessment during handoff between the OR and the PACU staff. This practice was a key driver for integrating their real-time root cause analysis QI process. The 10th key is to institute early movement, daily skin assessments, and pressure management. This prevents postoperative complications. For years, I've championed a horizontal approach to pressure management. We've seen this approach in infection prevention. Remember universal precautions? Well, what about universal pressure precautions? Horizontal approaches make the right thing to do the easy thing to do. As we look at all those areas where immobility occurs, we must proactively plan to standardize equipment and devices for redistributing pressure. By adding progressive mobility, movement, and prevention protocols, you can greatly reduce injury in these settings. And last but not least is closing the loop on reporting, particularly pressure injuries in surgical patients within 72 hours after the procedure. Because I didn't want my research to sit on a shelf, I created the Perioperative Pressure Injury Prevention Program. It starts with your quality improvement, looking at your data and performing root cause analysis as necessary. You want to sustain a targeted injury prevention program. You need this data to identify gaps in care and unsafe conditions. We've already discussed the gap analysis and integration of evidence and awareness into your practices. But one of the most important things to do is to collaborate with your interprofessional team. And this means that you plan your improvements with everyone from the OR, anesthesia, leadership, your wound ostomy continence nurses, and yes, most importantly, the surgeons. We need their buy-in for this issue. In conclusion, I would like to say, to achieve high reliability, we need leadership commitment to an ultimate goal of zero patient harm. The strategy will transform the safety culture by defining responsibility and accountability for all team members and leaders for actions and initiatives. We conduct that gap analysis that determine our strengths, weaknesses, opportunities, and threats. Focus on the low-hanging fruit. What can you do by next week or next month to improve processes? Integrate those tools and methods to drive change. Create innovative ways to make the right thing to do the easy thing to do. by using a horizontal approach to standardizing equipment and processes across the continuum. Invest in ongoing training and competency verification and proper documentation practices. And I thank you very much for your time.
Thank you, Susie, for your presentation. I'd like to thank you also for sharing your knowledge and expertise on this important topic. I'd like to remind our listeners, for you to receive contact hours for this presentation, you must complete the learner evaluation. Complete the evaluation by using the link in your purchase confirmation email or by visiting the AORN website. Once you have submitted your evaluation, you can print your certificate. Thank you for joining us today. This concludes our Nursing Continuing Professional Development activity.